Hello, good evening. I am Dr. Dan Sotiris, Asthma and Allergy Associates in Colorado Springs. Tonight we have a program via Medscape called HAE in Action, Redefining Control Through Shared Decision-Making and Novel Long-Term Prophylaxis. I should tell you, I have a baseline rule tonight. Every time you hear the phrase shared decision-making model, you should grab your drink and just give me a quick, Prost. All right, so that's a good ground rule. We have this evening Dr. Tim Craig and Dr. Elena Banerjee, who can introduce themselves a little bit.
Go ahead.
Sure. Well, good evening. It is nice to see so many people here to listen to us chat about HAE tonight. It's certainly an area of personal interest because of patients. I started in this area when I was a fellow, seeing a couple of patients with hereditary angioedema where we really didn't have any treatment options, and so ended up becoming involved in a clinical trial as a result of that to really help patients. And I can still say that today, even though I have a few more patients now, we are really helping patients, and a lot of what we do has made such a big impact, and we still have a bit of work to do, but hopefully we can share some of our perspectives with you tonight. So thanks for joining us.
Yeah, I'm Tim Craig. I'm at Penn State, about 80 miles west of here. So I have a very similar story. Actually, about 28 years ago, a person with hereditary angioedema, and I can use his name, Scott McCoy, he came into my office and said, "What do you know about HAE?" And I said, "I know I got the questions right on my boards, but outside of that, don't know much about it." And he said, "Well, I'm going to be back in 3 months, and I expect you to be kind of proficient in treating the disease." And that was, like you said, nothing was around. Androgens, FFP, that was it. And I think all three of us are really fortunate to have watched the unfolding of multiple drugs. And now, we have people who are completely symptom-free and have good quality of lives where, I used to write for disability all the time, and now there's no need for any disability. Still big quality of life issues, though, and still a lot of fear factor, but it's been really sensational to be part of the whole thing of drug discovery, and I'm really glad to have the opportunity to talk to you all.
Yes, and I'm in private practice in Colorado Springs with a clinical research center. The first HAE patient that walked into my door was a young woman who had a 2-year-old child. She had recently lost her aunt to, turns out, a laryngeal attack of HAE. And the woman said, "I don't care about me, I want to know if my daughter has this." I said, "Well, let's order some labs." And while the labs were working for a few days, I went to the textbook and started reading up again, and the labs came back positive for her and her daughter, and I called her and I said, "There are some research trials going on for HAE. You could really be a part of the solution now." And the woman said, you can't study me, and you cannot study my daughter, but my mother has HAE. I'll get her in here and you can do whatever you want to her." Great, so we'll move through the slides on that one. So we've got this Med Challenge. There's a QR code here. You can go head-to-head against your peers and earn points, deepen your knowledge. All that's available through medscape.org if you'd like to use that. You're going to use your own technology, offering an interactive experience during this event, and joining on your devices. All that's available. Great, so moderator, experts over here. Notice I'm not the expert. We've got Tim.
He is, though. Definitely is.
I'm good with dad jokes. They'll keep coming.
And poems. we got to find a poem tonight.
We might have a poem. So, unmet needs in HAE. HAE is a rare autosomal dominant genetic disease characterized by recurrent, unpredictable, potentially life-threatening angioedema attacks, upper airway, GI tract, and really any skin surface. The impact of HAE extends beyond its clinical manifestations. It can cause temporary disability. Tim made some nice points about that. Limit daily activities. Disruptive of school, work, and social life, leading often to anxiety, depression, and reduced productivity. The psychological burden worsens with attack severity, leading to cycles of emotional and physical stress. And the fear of the next attack and the pain associated with attacks can contribute to anxiety. So I thought maybe I should just outline a little bit about what an attack in HAE means. There's an attack from a person who might eat a food allergen where they have swelling of the lips, tongue, and mouth. That is an episode that's probably going to respond well to epinephrine, antihistamines, and steroid therapy. Usually that resolves fairly quickly with those therapies. People with hereditary angioedema do not respond to antihistamines, epinephrine, and steroid therapies. Their disease is mediated through an entirely different chemical cascade. And we need to use medicines that are specific towards that goal. Do you guys have any comments on this?
Yeah, so the swelling and the difference, like you said, how histamine is short in response to epinephrine. When you think about these attacks, last anywhere from 2 to 5 days. And the average person, depending on where you are in the world, but somewhere between 15 to 24 a year. So it would be like 6 months of disability a month. And you could see why prior to therapies, it'd be really difficult to maintain a job, really difficult to keep up in school, really difficult to go away to college. You would probably not want to be in an airplane if you had drugs, right? And that was kind of the usual. People would not go on vacation. If they did, it would be around the corner. They would definitely not get on a plane traveling over the Atlantic Ocean. So it really is, when you think about that, the persistence of symptoms, the recurrence of symptoms, and the really change to your quality of life and your anxiety, as you said, that builds up when you have a disease such as this.
Yeah, I agree with everything that you're saying, and we've thought a lot about this, and we've tried to follow patients over time, thinking about, back 10, 15 years ago, looking at quality of life and burden of disease. And even when you fast forward to today, and we have, 11 therapies in the United States, it's still shocking to me to see how poor quality of life is for our patients with hereditary angioedema. And a lot of that is because these attacks can still occur spontaneously, right? We have good treatments, but you could still wake up tomorrow with an attack. And even more, they have been living with this for decades. And the anxiety and depression is really hard if they've been living with this for decades. And so one of the things that I'm really optimistic about is we have done a much better job diagnosing children, right? So getting them diagnosed by the age of 1, telling parents it's really important to get your child diagnosed, because if we can get that early diagnosis, if we can give them treatments very early, maybe we can really impact this level of anxiety and depression early. And that's really my hope with where we're going with taking care of these patients.
I really appreciate that, Elena. And what is the average time to diagnosis for a patient with HAE?
It's quoted in the literature anywhere from 12 to 20 years. And I think there was a joke last night where we maybe moved from 12 to 11.9 years. But in reality, that's the truth. It's still years from the time that someone has initial attack symptoms till they're diagnosed in many places in this country. And so I think that even just making the diagnosis is still really important, and learning about it, educating our peers, our colleagues, because they're not necessarily showing up to allergists, right? They're showing up to GI doctors or the dermatologist or to the emergency room, and nobody really knows what it is, and they're being treated as if it's an allergic reaction. I still have patients who say they had an appendectomy because they showed up abdominal pain, and nobody knew what it was, but they thought, oh, you're having appendicitis, and they take out the appendix and the pathology is normal.
Great, thank you both. All right, so HAE cannot be cured. There are effective pharmacological management that are available and to help achieve disease control. The goals of HAE treatment are to achieve total control, normalize patient lives, and to have no angioedema attacks. This format tonight, we have Dr. James and Emma over here who are going to be giving us kind of a scripted interaction about reliving basically a combination of our experiences with patients over the years. I think we're going to step into clinic now.
Hey, it's good to see you, Emma. How's it going? Good. Busy. I leave for college in the fall. I got a band scholarship.
What? That's exciting. You think you're ready?
I think so. It'll be different to be on my own, but I've been feeling good, and my attacks haven't been too awful.
Good. So when was the last time you had to treat a swell? Or if you didn't treat, you had a swell, but you delayed?
Maybe about a week ago. It was in school.
Oh, tell me what happened.
My right hand began to swell when I was in chemistry lab.
That's tough. Were you able to treat that right away?
I know I'm supposed to treat fast, but with everybody looking at me, I just couldn't. I was in the middle of the room, my hand was puffing up, and I just kind of froze. No, not right away, but it still turned out all right. I have a friend at school, and she knows what's going on with me, so she'll come to the bathroom with me, but I had to go get her and then do the treatment, so it took a little while.
Yeah. How often does that happen, where you need to treat?
Not often. I'd say I treat maybe once or twice a month, depending on how things are going.
Okay. What if you counted every episode, both like full-blown swelling attacks, but also those early warning signs, like, but you don't inject? How many times a month is that happening?
Maybe 3 or 4. Sometimes I think it'll stay mild, so I just try to push through it.
Yeah. And that is something we should talk about. I know some patients feel like they really can tell, like that their attack is going to stay mild or that it's not going to progress. But there isn't really good science to back that up. It's like when we do that, we're really just guessing.
Yeah, that's pretty much what I'm doing.
Yeah.
Guessing and then hope I'm right.
So, I mean, and for you, you might have gotten so used to your attacks that they feel normal to you, but it doesn't have to be that way. How do you imagine HAE fitting into your life in college? Like, what would feeling in control look like for you?
Honestly, I'd love to not worry about my hand blowing up into a life-size balloon or missing band practices. Yeah. I'd like as few attacks as possible, so maybe none. Am I even allowed to ask for that?
Don't you love Emma? Like, I really want her to succeed in college, I got to tell you. Elena, does this bring back any memories to you, any interactions?
Yeah, I mean, this is the reason why I'm so excited for our patients, for the treatments they have, the treatments that are out there, and to really have an impact on their day-to-day. I think that what you hear from Emma is exactly what's happening in our office. We have patients coming to us choosing not to go down a certain career path because they really have missed so many days of school along the way and just don't think that they can continue to get an A in a class when they're missing multiple sessions or quizzes and exams throughout the year. Or choosing a different career path, really because those doors they didn't feel like are open to them. But even simple things like you heard Danny say is going on vacation, right? It's impossible to do that when you just don't know when your next attack is going to be. And I think one of the things that Emma highlighted that I want to really mention is the amount of time that it took for her to treat, right? So we know that these treatments work much, much better if you use it early because it helps the symptoms from getting worse. And that she, as a student, has to find either somebody or some place where she's comfortable if she's using an injectable to treat the attack. And so those are all aspects of taking care of patients like Emma that we really have to ask about and think about and make sure that we're addressing.
How about you, Tim?
Yeah, it kind of makes me think of the story of a woman I know in North Carolina who wanted to go to nursing school, and exactly what you mentioned, she never did. She was afraid to. Her mom, however, was totally disabled, often wouldn't come out of the house because she would have facial swelling, and she was afraid the neighbors would think that her husband was beating her. But this lady who wanted to go to nursing school wouldn't. She had a much better quality of life because the early therapies were already available, IV C1 inhibitor and a few other drugs, but not drugs that were easy to administer, not drugs that were you could easily stay compliant to, which is now is out there. But she finally, her daughter now has access to the drugs that are out now, and finally decided she went to nursing school. So her mom finally decided to go to nursing school with her daughter. She got the courage because of what has developed over the years. But still, you're right. People aren't always compliant to their therapy. Even the best of us forget to take therapy occasionally. It's to remember to take it. We know with food allergy, how many times do people not have their EpiPens with them? And then you're on a prophylactic medication now, you have to remember to always carry your rescue. So, despite all the advances, you're right. People are still having attacks. Compliance has been an issue. Even those people on prophylaxis, when you really look closely at the data, and we'll talk about quality of life instruments in a little bit, you can see that people are not as well controlled as us physicians think they are. And so that's why it's important to do quality of life and control tests and so on to ensure that you're really capturing the patient's history.
Yeah. I'll just pull together a few points that were made. Imagine this individual didn't have the correct diagnosis for 10 years to 12. Imagine that each of these 3 or 4 attacks a month is lasting 3 to 5 days. We're talking about this young person losing potentially, 15 to 20 days of the month of productivity. So we'll keep moving. There's tons of stuff. I love the interaction between the provider, between Dr. James and Emma. Think about your own interactions with healthcare providers in your life. I love that Dr. James asked Emma, what does control mean to you? And in honor of where we started, that's part of shared decision-making. So I'm going to do this, and I'm going to hand the clicker over.
That's right. We have to drink water.
How come we didn't get any wine up here?
Oh, you've got your own clicker. Great.
So, I was talking about quality of life. And so this is one of the patient forms that I think are helpful. It's a little bulky. It's 17 questions. So it is really difficult to use in a clinic. I use the control questionnaire, which is the next thing I'm going to talk about. However, in research, this is frequently used. It has a couple things that make it easy. So it's based on 100, and if you have a change of 6, that is clinically significant. So it's easy for you in clinic to use it. It's just difficult because of the 17 questions for a patient to fill out. But, you can conquer that easily if you have, some way of people doing it while they're in the waiting room or, in the patient room themselves as they get in, waiting for you to come in. It's basically focuses on work, quality of life, the ability to do physical exercise, social relationships, and eating and drinking, which is kind of strange. We'll come back. I wanted to ask Dan what he thinks about that. It also goes into sleep, and that has a lot to do with anxiety, as we probably all know. Also cognitive and emotional well-being, dietary and lifestyle limitations, because of recurrent abdominal pain. A lot of people are worried about certain foods, and in fact, if you look on the net, there's all kind of information that certain foods stimulate HAE attacks, and it's probably not the case. It talks about the anxiety and, like you said, the post-traumatic stress syndrome that people experience, especially from having a disease early in life, and then social and emotional impact, and then even concerns about treatment. One of the drugs that are out there, it's a very nice drug, but when you inject it, you get a significant injection site reaction, and that's probably why Emma is leery about using some of her drugs. Or in the past, when you needed only IV drugs, you would teach people to self-inject, even 8-year-olds who would teach to self-inject. Now, thankfully so, that's not as much needed. And in fact, I think I've moved away completely from IV drugs, except for a short-term prophylaxis before surgery and before, say, dental work and so on. The other form, I think, which is I'm very comfortable with using in my clinic, it's very similar to the ACT we use for asthma, very similar to the urticaria control test, but it's a 4-question. You can reflect back 3 months, I don't know, maybe I can't reflect back 3 months, but I trust my patients can. And so it looks at the frequency of attacks, and it is amazing. And I'm sure both my colleagues will say that, hey, patients come in and say, I haven't had an attack in like a long time. And then, they sit there and I talk to them and all of a sudden find out, yeah, just like Emma. Yeah, they're having other attacks, but they're mild, or they didn't treat them, or they weren't sure, what to do. Also, it talks about the impact of angioedema and what their function is and all those things we talked about, going on vacation, going to school, going to work and, being productive. There's nothing worse than your hand swell and you get to work and you can't keyboard, or you have a foot swell and you can't drive your car. And then it also talks about therapy and what they feel about their therapy. So it's pretty comprehensive, 4 questions, 3 months to look back. I think this is very effective in a clinical situation. I don't know, have you utilizing it?
I enjoy this angioedema control test for sure. The other one, the eating and drinking, somebody has a mystery disease for 10 or 12 years, there's a tendency to develop some myths, internal myths about what might be causing it. And so it's natural, I think, that a person, a family goes through a journey of thinking it's related to a food. And now, of course, with Dr. Google, there's tons of misinformation for people to pursue. So I feel like that in the AE quality of life questionnaire, the earlier slide, that eating and drinking, it's really not so much of a thing, and I feel like it might actually change the results of that questionnaire under the wrong circumstances. So.
And how about, are you using a instrument?
Yeah, we use the AECT, and partly because it is a little bit more straightforward in terms of the number of questions that are being asked. It's very simple. And getting a better assessment over 3 months is useful when we're seeing patients in the clinic. And so we're tending more towards the AECT right now.
Okay.
So in terms of some of the things we think about when we are taking care of our patients with hereditary angioedema, we really talk about 3 big buckets of treatment. And 2 of them are things that we talk about all the time. So on-demand treatment. So this is giving someone like Emma treatment right at the onset of an attack. And what you really want to do is use treatment as early as possible, like we mentioned. The other big category of treatment for our patients with hereditary angioedema is long-term prophylaxis. And so I don't really think I need to go into a lot of detail with this audience, but what we're talking about is using regular treatment to decrease attack rate overall and really just improve quality of life and reduce burden of disease. And then one of the things that we don't spend as much time talking about, but is just as equally important, is short-term prophylaxis. And so that means using treatment before a known trigger. And I think you've heard my colleagues already talk a little bit about dental work or surgical procedures. And so we want to give them treatment to prevent that trigger from causing an attack. And so we always want to think about these 3 treatments when we are seeing our patients with hereditary angioedema. And so this would be similar to an asthmatic that needs a daily controller therapy. So that's their long-term prophylaxis, their albuterol or their rescue, which is their on-demand treatment. But also, for example, if they were to get sick, what is their action plan when they get sick? And so I think when we think about it in other conditions, we're a little bit more familiar, but this is very much what we're talking about with hereditary angioedema.
Could I add something to that too with the short term? Not only surgical procedures, dental extractions, maybe not just cleaning of the teeth, any medical procedure, especially if it crosses the airway. But then also for like if you're getting married, that might be a time you want short-term prophylaxis. On your honeymoon, it might be a good time. If you're taking your exams and you're in medical school and you don't want to miss your exams, so that might be another time. So short-term prophylaxis, we don't spend much time talking about it tonight, but it is an important part. And like you said, what we do, we have a card with their on-demand therapy and the long-term therapy and how to treat for the emergency room physician. But then we also have what they should have for their short-term prophylaxis. And we always tell the people to call us because each procedure may require a different amount of short-term prophylaxis. Some might need IV C1 inhibitor right before a procedure. Others, maybe androgens would be adequate for short term. So I think it's really a thing that a lot of my patients, they need to know how to get hold of me, and maybe even have my cell phone. That's maybe not a good idea for everybody to do, but it allows them to call, though, when they have a procedure or an emergency, so they can get some idea of what to do in that case.
Yeah, no, I completely agree with you, Tim. And it's really just helping the patient understand what their known triggers are, right? So, for example, it could be a vaccination. It could be getting married or travel. Whatever it is, if there's a known trigger, we want to help them make sure that it doesn't develop into an attack.
Yeah, every time I get married, I get no.
I was thinking, along the lines, something, Elena, you brought up earlier, 11 medicines FDA approved. 20 years ago, 0. So 5 in the on-demand space, 6 in the long-term prophylaxis space. Short-term prophylaxis, we're using things that have been shown to have value. So it really is, and I spend a lot of time educating patients, like I might with an asthma patient, that your controller medicine can stay at home, but your on-demand medicine needs to travel with you, right? For food allergy, you mentioned with epinephrine. No, it needs to go with you all the time. And so the same sort of communication in the HAE space about the medications and their roles.
Yeah, great. So what do we think about when we are talking to our patients with hereditary angioedema about on-demand medications? There are numerous guidelines out there. There's the HAE guidelines, of WAEACI guidelines, there's a Canadian guidelines, there's a pediatric guidelines, but they are all very consistent about certain things. And one of those, in terms of on-demand treatment, is that every patient with hereditary angioedema should have at least 2 doses of on-demand treatment. And I think our panel would generally agree that it's the same medication, right? We're not talking about 2 different drugs. We're saying 2 doses of an on-demand medication. They should be educated to treat every single attack. So it doesn't matter if it's a peripheral hand attack, if it's an abdominal attack, and as much of a laryngeal attack where you would always treat. We say that every single attack should be treated. And why do we say that? One, it's because that attack can progress. It can be more severe. But even if an attack, such as my hand swelling, isn't going to be life-threatening, it is going to impact my day-to-day, right? So if my hand suddenly became swollen, or we all woke up and our hand was swollen, you can't use your phone. You may not be able to drive. You might not be able to get into work and use your computer. Can't check Dr. Google, right? So there's so much impact, even if it's a hand swelling attack. And so we want to make sure that patients understand that as our physicians are advising them, treat every single attack and then treat it as soon as possible. And those reasons we've already talked about. Any perspectives when you see these guidelines and talk to your patients about them?
The guidelines are critical as a communication tool to patients. But honestly, I think maybe some of this audience might be familiar with a payer issue in this space and in clinical practice. And so, those individuals, the payers, we need to be able to present to them guidelines justifying, because they need to be able to treat 2 attacks, not just 1. They need to be able to treat every single attack. And there shouldn't be limits on this, because there are powers that are trying to limit access to these available treatments.
Yeah, unfortunately, the guidelines are read mainly by those people who know about the disease. And, one of the things we find in emergency rooms, you mentioned it, is a lot of times they have no information. They know nothing about the disease. So patients go in with abdominal pain maybe a few times in a row, and then everybody starts thinking they're drug seekers. And they often have, I've had quite a few young ladies who had unnecessary surgery. And so it really is, I don't know how the best way is to get guidelines to everybody, but that's what we really need in this disease, in all rare diseases, because a lot of people who treat them emergently really don't have much insight. One of the saddest cases I had was a man moved from New York to Pennsylvania, and he was on lanadelumab, and then his script was up. So he was waiting to be seen by another doctor, and he had an attack in the morning, early in the morning, and he woke up, treated himself with a icatibant, And then, you know, I always tell all my patients, if you treat an upper respiratory attack, you need to go to the emergency room. You cannot wait. You go, you treat yourself, and you go. He chose not to, and he went back to bed, and a couple hours later, he woke up, and on his way to get his second dose of icatibant, he died. And right there in front of his little baby, too. And so now, actually the family the baby was only 1 or 2, but here the wife, you know, always never saw an attack before, and now she has this young baby who also has HAE, and the husband dying of HAE, which added that excessive stress into it. So, you know, that's one of those things that very, very important that with shared decision-making and information to make sure patients know what they should do in a critical situation like an airway attack.
Yeah, no, Tim, I appreciate you sharing that because I know that that's something that's challenging. And we can talk about these guidelines and we can tell Emma and we can do all these things. But the point being that fatalities are real for patients with hereditary angioedema. You shared a case. I know of several cases. And one of them is somebody who knew they had HAE. They were on the golf course, playing, you know, teenager, and was on prophylaxis, started to have an attack, and called his mom and said, hey, meet me in the emergency room. I'm having a throat attack. Bring my drug. And by the time he got to the emergency room and was triaged, he actually ended up having an airway attack and died. And this is, again, known patients with hereditary angioedema. They have treatment, and yet it is a fatal condition. And so I think a lot of the things that we talk about are so important because we know fatalities are real, and we have seen them, we've heard about these cases. And so I think it's really important to just continue to be telling patients about these aspects, like treat as early as possible. And where's that drug? It needs to be with you. And so, you know, that really brings us to this aspect of data. So what are patients doing, right? We can say, Emma, use your drug, use it as early as possible. But the data shows that 1 in 5 attacks in our patients with hereditary angioedema are untreated. 63% of the time, they're not always carrying their medication with them. That's a lot. It's not surprising. I mean, we see that with food allergy patients and epinephrine. They're not carrying their medication with them. And more than half don't necessarily treat all of their attacks. And so clearly, I mean, this is 2024 data. Clearly, we have work to do. We have 5 treatment options now for patients with hereditary angioedema. So we need to get them into the office, use shared decision-making, and really think about what is their perspective, how can we help them. And I'm just going to put in a quick plug here for the HAEA Patient Association, they've really done tremendous work. And what they've actually done most recently is created a shared decision-making tool that's on their website. And a patient can go online. It goes through a list of a few quick questions that you can just click a box to answer the questions about treatment preferences, tolerability issues, preferences, things that we talk about in shared decision-making, but then the patient can get a PDF printout and take it to their appointment to their physician. And so I think as a physician, I would love for my patients to do that. But patients can also then have a better way of expressing their perspectives because it's asking the right questions, and you can go into the office with those so that we can have a better conversation about all of these treatments. Are you seeing these data? I mean, is this surprising to you, or is this what you're both seeing in your practice?
I'd say it reflects my experience in the practice for sure. And again, I see a lot more food allergy patients. You know, this is a very rare disease. I guess 1 in 50,000 people with this disease, a country of 300 million people. We're talking about 6,000 to 8,000 people in the U.S. with hereditary angioedema. I see 1,000 new patients a year in my clinical practice. I take care of 40. Anyway, I see 40, however you want to count that, HAE patients, type 1 and 2 HAE. So it is reflective of human nature. You know, our food allergy patients are not carrying their injectable epinephrine, and our HAE patients are often not carrying. I think it actually points to the wonderful relationship that Dr. James and Emma are developing in terms of our role in shared decision making and empowering an individual into their mind. Back to that question, how do you define control? What are your boundaries for, you know, being responsible for this disease? And their next scene is kind of neat. They'll carry that forward as well.
And so, you know, why are the data so bad? Why are patients not treating? And I think there are some really good things here for us to really understand, right? So the single most common reason is they're not sure that the attack is severe enough. But why? Why? So they're not sure they're going to have another dose. They don't know if they can pay for another dose, so they don't necessarily want to use it for this attack. And so that's a really important conversation for us to have with them. And then certainly the things that we've talked about, right? Not having it with them, anxiety about getting another refill, side effects, which you heard us talk a little bit about. And then again, what you heard from Emma is, where am I going to go to give myself the treatment? And so I think these are very clear, valid reasons for why the data are what they are.
I did want to add with the cost, so, you know, if we spend a lot of time, we have a nurse specialized in HAE, and she is able to always get copay assistance for everybody. So these drugs are $500,000, and, you know, I think some people respect that, you know, it's an expensive drug. It's still, you know, we have to encourage them to use it because exactly what you said. They think, wow, this is just too pricey. But in the sense of putting the burden on them, we're able to get everybody a copay. So I don't think any of our patients are paying any money. It's very difficult, you know, when you have Medicaid and Medicare patients. But, you know, working to get in with nonprofit organizations will pay copays for patients. And one of the things you do if you have patients and you need that information, call one of the centers or even the HAEA. They're a very good source of helping you get copay assistance for these patients because most of us in the room who are doctors couldn't afford our copays for these.
So we'll step back into the clinic.
So tell me if I have this right. You're using on-demand like once or twice a month, and if you treated every episode, we're probably talking like 3 or 4 attacks monthly?
3 or 4? Is that true? I guess only counting half of them made it sound a lot more manageable. Yeah, I didn't realize it was that often, but yes.
Yeah, I mean, and soon you're going to be even busier. You know, you'll have classes, band practice, making new friends, going to parties. So you won't really have time for 1 or 2, 3 or 4, 1 or 2, any attacks, right?
Yeah, no, but what can I do?
What do you think about starting long-term prophylactic therapy?
I tried that a couple years ago, remember? At first, my parents were giving me the injections, and then I got to a point where I could do it myself, but then it left these marks all across my stomach, and I really didn't like that. Plus, it was every 3 days. Every time my mom entered with an injection, I would sprint in the opposite direction. She almost signed me up for track team.
No, I remember you were not happy. So we took a break, we reset, but we have some different treatment options now.
Really? Like what?
Well, there's a few new treatments available to us. There's a daily pill. There are a few injectables. Some of them are just once a month. A few of them are every 2 months for some patients.
I think the less I have to think about taking my medicine, the better.
Okay, all right. So if your goal is to get to 0, as close as you can, right, to 0 attacks with as few injections as possible, then we're going to focus on options that are low volume, dosed less often, and that aren't really associated with like injection site reactions.
So yeah, I was a chief resident in internal medicine before I went into my allergy fellowship in New Orleans. And I loved teaching the art of taking a history and teaching first and second year medical students how to do that. There really is some science behind it. And I think Dr. James does a great job. And actually, each of you, when you meet with your healthcare provider, you should pay attention if they do this. She repeated back what she had heard from Emma to start the conversation. Let me be sure I've got this straight. And that takes Emma on a personal journey where the doctor is doing the most important thing in the room, is listening. And right in the middle of that is another thing we used to call the window of opportunity. When Emma says, no, but what can I do? And that is the moment that the trained provider, now I've got this adolescent young woman asking me questions rather than I'm talking at her. And it really is probably one of the most critical steps to teach a young person, and maybe some adults, how to take care of themselves and how to get that conversation right. It's the thing that we get paid the least for, actually having a conversation with our patients, but it truly is the most important thing we do. So that's from this interaction, probably one of the most lovely things that I appreciate. Anything stick out to you?
I think when we start the conversation about long-term prophylaxis, we also want to bring the guidelines kind of into that, and really just to say that every single patient with hereditary angioedema is a candidate for long-term prophylaxis, and I truly believe that. I mean, I don't think there's a single patient that could come into my office with HAE that we wouldn't have the conversation.
And the guidelines actually state that shared decision-making should be done with every patient each time you see them, and the determination of long-term prophylactic therapy should be a decision between you, driven by the patient.
I think we've missed like 4 chugs.
Mm-hmm. I did want to do a little case because you brought up sports. A lot of times people think that, hey, this is HAE and triggers such as trauma can really trigger an attack. So why would you let people do that? But one of my favorite cases was a young man who was a wrestler. His dad was a wrestler, and so was his brother. And the year I put him on prophylaxis, he went on to win the state championship and actually got a scholarship to college for wrestling. And you'd say, what? That's insane. Why would you let someone do that? But you want to have people to be older, capable of being, and you can do that now. Years ago, very difficult, but now you can.
Love it. Wrestling's a tough choice out of the HAE
I know.
sport choices. Maybe swimming or... Yeah,
I tried to talk him into chest, but that didn't work.
So Dr. James and Emma have set the stage for us to talk about long-term prophylaxis. That's kind of our main theme tonight regarding hereditary angioedema. And as Tim alluded, these are my slides, right? Have we lost the color code? Or
This is mine.
Oh,
Yeah,
go get it,
but that's
buddy.
okay.
Yeah, you go.
So, but you already talked about it, so this is perfect. So the guidelines, the main thing the guidelines stress for long-term prophylaxis is exactly what Alina said, is that shared decision-making, talking about to the patient about what's out there, what it can do for you, how it can improve your quality of life, and then letting them make that decision to either go on long-term prophylaxis or not. And now, we have multiple drugs to talk about. Like mentioned, oral medications, which that's probably great for some people, a pill a day, but we have some other medications that are injection once a month and maybe even less. And, I don't know where I stand, when I think about that. I might go for an injection once a month instead of a pill every day. But, 25% of Americans hate needles, so they obviously, they thought that group of people would go for a pill rather than an injection. More than that, the guidelines are really good. They go through the drugs. If you ever get a chance, if you have a patient, you really probably should read through them, and just so you can see the flavor of the guidelines, because it really is it'll increase your ability to maintain your patient in a state of maybe good quality of life, and where they don't have to worry about what we've been talking about. So the drugs that are out here now, these are actually, these weren't on me initially, but so we have a variety of drugs. So we have C1 inhibitor, IV. That's what Emma, I think, was on at one time, or maybe the sub-Q version of it. It's a great drug. They work. One requires IV, and every 3 to 4 days. That's a big burden. People often got ports, which led to clots and so on. So I've kind of moved away from IV for those obvious reasons. Sub-Q works too, but again, every 3 to 4 days, and it's in your belly, and it is a pretty large volume, 6 cc's, 8 cc's, sometimes if you're big, even 10 cc's. So that's a little bit of hassle. But then, a couple of years after these 2 years after these drugs are available, then came lanadelumab, which is a great drug. It was once every 2 weeks. If you were in good control, you could go to once a month. That made that barrier or that burden much less of using it. And then we have, more recently, berotrostat, which was the first pill. That is easy for some people. Grant you, it's not as effective as the others, but it gives you a choice of going to an oral medication, which is less burdensome for a lot of people. And then more recently, garadacimab, which is once a month. Some data suggests you can use it less frequently than that, but the package insert says once a month. And then also donidalorsen, which is the newest of the drugs to be approved, and that is approved for 4 weeks. And then if you're doing very well, you can edge out to every 8 weeks. And the garadacimab, donidalorsen, and lanadelumab are all sub-Q, which makes it easy for a patient to give, and then much less volume than sub-Q C1 inhibitor. So we have some really nice drugs out there, and we'll talk about that further in a little bit.
Tim, go back to the last slide. I would like to make a point, because I'm not sure.
Oh, can I?
I think you can go back.
Oh, yeah. I can.
So I would just, at the beginning we talked about how this is a disease that is not responding to antihistamine, epinephrine, steroid. Notice the alphabet soup of names here, all the different chemical cascade differences. There's a really elegant, well-defined biochemical cascade that leads to HAE attacks. And one of the core issues is being deficient in the protein C1 inhibitor. That's why C1 inhibitor replacement helps this disease. Involved in that cascade are multiple other chemical steps leading to the production of bradykinin, which actually is the chemical cause of the leaky vessels and the swelling episodes. And all along that kind of snowball effect of biochemical events in a person's body, we have ways to disrupt that, right? And that's really the mechanism of action of all these drugs. That's just a level set of what all of those extra names are there.
I can go ahead.
Yeah, move forward.
Nice guy.
I don't know. Elena's got it.
Elena? Oh, wait.
I do not
that's
want to be
true.
talking about more than that
Okay,
Friday night to our audience.
Yeah, right.
Who's ready for the next slide?
Okay. So phase 3 studies have shown a variety of things, and that's phase 3 studies are really great. It's what you need for the FDA. But really, I think the best take is looking at the long-term open label studies, because then you see a real kind of human experience. And when you look at certain drugs, you might see like 81% effectiveness and reduction of attacks, which is usually a primary outcome. And then you look at that same drug in an open label, and where people know they're getting drug and they feel more confident, they have less stress. And then all of a sudden you see that same drug now, approaching 90% reduction of attacks. So, phase 3s are great, but I always suggest that you should go and look at the open label studies as well, so you can get a more true insight how it affects a person on a daily basis. More than that, I'm not going to comment on this slide.
No.
Anything else you want to make?
No, I was half joking. It is really important. I mean, the reason that we can do a better job taking care of our patients is because we have 6 great drugs for prophylaxis for our patients. And the guidelines would actually say that they're actually all first line. So the guidelines were written at a time where many of these medications hadn't been FDA approved. But the guidelines would suggest that all of those therapies are first line treatment, meaning that other therapies such as androgens and antifibrinolytics are second line. And then what Tim was saying on the prior slide is really that they all work. They all are safe. And it's really then us talking to patients, as you heard, talking about what is important for the patient. Is it something that I don't want to be thinking about my disease, so I want the dose of drug that is least frequent, and I don't want something that burns, and I want to be able to just leave home, not worry about it, not have to take a pill every day, for example, as we heard with Emma. And so those are the kind of things that we should be thinking about.
So those drugs we just went through, one of the things they all do have data suggesting they improve the quality of life, usually, in the 20 range. It's a scale of 100, so that's a significant statistical. They only have to move 6 points to really have a clinical benefit. And those, the quality of life, as I mentioned, on the other slide looks at functioning, looks at mood, looks at eating even, or nutrition, looks at shame, fear. So it is a pretty comprehensive way of evaluating a person and how they feel about themselves. And the AE-QOL, which I mentioned 5 or 6 slides back, really is effective at looking at this, at least in a drug study, in a phase 3 and an open label. Like I mentioned, a little more of a burden in clinic, and I think the control test is easier to use. But I think it's important that every one of those drugs that I mentioned all improve quality of life statistically. So,
more details regarding the long-term prophylaxis for patients. This breaks it down into the indications by age, the mode of administration, and the dosing strategies. The information's available on the slide, and I'm just going to, Tim has done a great job reviewing the broad strokes here for C1 inhibitor, lanadelumab, beroltrestat, garadacimab, and donidalorsen. I'll point out that lanadelumab does have that younger pediatric indication. I'll say we were working on ad boards together probably 15 to 17 years ago, asking companies to help this population of children, who have HAE and who were not having great therapeutic options, and they went and got that indication. We now see beroltrestat has gotten down to that 2 to 12-year-old age group. I mean, that's impressive, requires commitment from those companies, from individuals to volunteer their children to be in trials that are placebo-controlled as well. And then we have the other medication options as well.
I do want to say that going back on that 2-year-old for lanadelumab and beroltrestat, it is amazing that I have quite a few people who are children who are on prophylaxis now. And, I'm hoping exactly what you said before, that these kids are not going to suffer from post-traumatic stress syndrome from having attacks when they're young. And to have these medications now, it's been so unbelievable that kids are not having any attacks. Some of them don't get good care. Some of the parents don't take good care, but the majority are doing very well. It was such a big addition, I think, to the disease state. And I think it'll really going to allow us to change how people's effect is when they get to be adults because of maybe putting a limit on that post-traumatic stress syndrome that children have.
Yeah, and one of the data points that we heard yesterday that we were talking about is that 40% of children have had an attack by the time they're 5 years old. And so if you think about by the time you're 5 years old having an attack of HAE, this is why this is so important.
And I'll point back to the relationship with the provider. Learning the language of your disease state is an important thing. I did internal medicine and pediatrics in my residency, and it was not uncommon for children to not really know the words to say, I'm having an asthma attack, or I've eaten the wrong food. You might see a change in mood or attitude. And with hereditary angioedema, learning the language of how to describe your disease, your disorder of ease, right, is a very specific thing, and it requires years of training and a fantastic relationship, hopefully social family support system, and the relationship with the healthcare provider.
So Alina did mention, so I do the same thing she does. At 1 year of age, I make the diagnosis. The biochemical tests are pretty reliable. Sometimes they're not, and I get a genetic test early in life just to confirm, to make sure if there's a gray area in the biochemical test. But then what I do, even though that person's not going to go on, has no attacks, but I know they're susceptible to attacks because they have the abnormal protein, right? Or the lack of protein, I have medications available for them at home because a lot of emergency rooms don't have the drug, right? So it's there at home. They can brown bag it in to an emergency room. I don't expect, say, a mom to know how to use an IV medication or a dad, but they can bring it to the emergency room with them. Or there are some injectable drugs that are sub-Q. So that allows the patient, when they have their first attack, to have something available. And I think that's really key. You don't want to make the diagnosis and then, because the person's not having attacks, to send them home wait until that first attack, because that first attack could be a throat.
Yeah, I'll just echo what you're saying, Tim. I think that first, making the diagnosis is really important, right? And trying to make that diagnosis as early as possible. And I think you've heard that from all three of us tonight. But that we should be giving them treatment even before their first attack. And I just think that that is such an important point that I wanted to highlight that again. Mm-hmm. And so, we've heard about the 11 treatment options that we have available, including the 6 currently available FDA treatment options for long-term prophylaxis. But amazingly, there are actually 5 additional emerging long-term prophylactic treatment options in addition to the 6 that we have. And so just quickly to highlight, there is Decryptivant, which is in phase 3 studies, and it's an oral once-a-day long-term prophylactic treatment option that actually binds at the site of the B2 receptor. So it prevents bradykinin from binding to the receptor, and so it prevents the increase in vascular permeability that we would see. And then we have NTLA 2002, which is actually taking advantage of a new technology with CRISPR-Cas9 that we've seen emerging, but specifically within patients with hereditary angioedema, it's targeting the plasma kallikrein. And so it's a one-time IV infusion using CRISPR-Cas9 technology to decrease plasma kallikrein levels. And then navenibart, which is a subcutaneous injection of a monoclonal antibody inhibiting plasma kallikrein. And also NTLA 2002 and navenibart are in phase 3 trials. Navenibart would be dosed potentially once every 3 months or once every 6 months. And so all of these are theoretically moving the needle a little bit differently from what we currently have available. And then we also have ADX 324, which is using siRNA technology, and it's a duplex oligonucleotide that inhibits prekallikrein, and it's given subcutaneously much less frequently. And then BW20805, again, these are developing their names, and that's using GalNAc technology. It's conjugated to siRNA and also inhibits prekallikrein and given subcutaneously. So I think 5 new treatments on the horizon, offering more promising options for our patients with hereditary angioedema.
I guess really 6, because Decryptivant can be long-term prophylaxis, and then they have a rapid onset for rescue.
Right. We didn't talk about the oral options in development.
Yeah. Are we ready to go to clinic?
Yeah.
I can't wait to hear what Dr. James and Emma decide.
So, some medicines work really quickly after a loading dose, and then others build up over a couple of months. But either way, you always need to have your on-demand inhaler with you and act promptly if you have an attack.
So I'll still be using my on-demand?
Yes, it's possible. I mean, maybe not, right? But we have to be prepared for attacks with all of the options. I mean, even on prophylaxis, you should always keep at least 2 doses of your on-demand therapy with you. I mean, as the prophylaxis kicks in, right, we can expect your symptoms to be less severe, to be less frequent. And, since you're not leaving for college just yet, we have time to move you closer towards your goal and let you head off then and change the world.
Change the world? Why don't we start with me doing my own laundry first? That sounds incredible, Dr. James.
All right. Now, the first step is for you to answer the phone. I know. You're going to get a call. It's going to be from a number you won't recognize, and you need to pick it up. A lot of work goes into getting these medicines approved and delivered, and if you don't answer the phone, everything grinds to a halt.
Okay, I'll even answer spam calls.
Wow, that is commitment. I like it. Okay, so I want to see you back here about a month or 2 months after the first dose, just to make sure we're moving in the right direction, and we'll look at how many attacks you've had, if you've had to use the on-demand therapy, and whether or not this plan is going to work for an academic amazer, band boss, full-time college rock star.
Let's hope.
I'm really optimistic about Emma's future, I got to tell you. So, optimal treatment selection involves a patient-specific approach. I'm going to just kind of move through these. There is an opportunity for question. We got about 15 minutes left in the program. I will say that the phone call thing is an interesting point because, as Tim alluded to, the medications, they cost money. The companies that have these medications, they offer sensational programs and benefits, really, for most patients. But they do have to answer their phone, and it's amazing how much that slows down the process. So review the benefits and potential risks of long-term prophylaxis. These are generally well tolerated. We've talked about that. Really among them, the most common adverse events are mild and include injection site reactions, upper respiratory infections, hypersensitivity, nasopharyngitis, and dizziness. The oral LTP therapy has some reported GI symptoms. Again, this is the type of thing you're working through with your provider after you've made a decision to go down a particular pathway. We can address any concerns and misconceptions. I love the follow-up appointment in a month or two to kind of see where we're at with the process. And of course, we're taking into balance the disease burden, the risk profile, and the patient expectations and preferences. I think Dr. James and Emma did a great job doing that for us. So there's also the issue of switching long-term prophylaxis medications. The changes in medications or dosing should be considered. So a patient, what that means is a patient who, well, Emma has not been on a long-term prophylaxis. When she was much younger, she was, but she's been off. A patient who might have been on a product for a period of time and wants to space out the shots. They're not having the effect they were once having. Any number of life events. So in accordance with the current guidelines, the expert panel recommends regular assessment of the efficacy and tolerability of long-term prophylaxis to adjust or switch prophylaxis according to disease severity and the patient's response to therapy. There are so many great choices now. The conversation is getting more and more complicated, but as they roll out, many patients want to know what's available. Patients often want to switch their long-term prophylaxis because of needle or vein fatigue, pregnancy, lactation. Elena, 2 advisory boards ago, you and Dr. Bussey brought up at the meeting the importance of family planning, and it made me reflect on all of the women of childbearing age that I take care of with HAE. They don't address that with me aggressively, and I actually made a personal note to myself that when I have a patient of childbearing age, as a guy, I think I have to be a little more assertive is not the right, but be more open to listening about where they are in a family planning stage, because that would be a situation where you might be changing therapy for a patient.
Exactly.
Can I just say that, first of all, you have an impressive memory to even remember that we were talking about this 2 whenever boards ago.
Yeah.
And I am thrilled to know that I made such an impact on you.
It's an honor to be up here with you, and you, Tim. So other reasons might be painful or intolerable injections, too much volume. Emma kind of talked about that experience, lack of efficacy or poor response, and then adherence issues. Very human and real things. So the key takeaways. Elena, where are you at?
I would actually like Dr. James' phone number because I'd like to schedule my daughter to see her because clearly she knows how to get her patients to do their laundry. No, I think that what you heard from us tonight is exactly what we are seeing in clinic, that we have tools. We need to continue these conversations, use a lot of shared decision-making, and that we have a long way to go because we need to continue to have these conversations and understand why there are gaps in what our patients are choosing to do. That it's not just them saying, well, I'm not going to do this, because there's real reasons you saw as to why they're making the choices that they're making. But for us also to make sure that we're asking the questions, that we're understanding their perspectives, and then having these conversations with all of the options that they have, and that it's an ongoing relationship and an ongoing conversation that was built on trust, which you heard Danny talk about, that starts in the beginning, and that we're going to continue to follow them over time. And that not everything has to be done today, not all the decisions have to be made today, but that I'm going to talk about some things, have them come back in a few months, talk to them about some things that are relevant to them, asking their perspective, and that it's not a decision that they are making that is ongoing forever, right? So sometimes they're worried, well, what if I want to change my mind? And I think that that's something that we have to be clear with them, is that they can come back, we can talk more, and that it's an ongoing conversation.
I do want to add one thing to that. It's kind of my summary of it. So I think we've made great strides for hereditary angioedema type 1 and type 2. Unfortunately, those people who have hereditary angioedema with normal C1 inhibitor or type 3, 2 syllables instead of 12, kind of like to say type 3 instead, but we really haven't made strides, and that's something that we really need to do. It's a population that's very needy, and really what therapies to use and ruling out histamine-induced disease before you give that diagnosis is so key. And I think, hoping that in a few years we'll be able to talk like this, showing that we have a lot available for that population as well.
We have 4 questions from the audience on the iPad here. Dr. Banerjee, there's one specifically for you.
Oh, great. I'm glad I'm making an impression tonight.
Please describe how to successfully diagnose younger children with HAE. And are you doing this with genetic testing?
Yeah, no, that's a great question, and we kind of talked around it. We believe that around the age of 12 months, the lab values of C4, C1 inhibitor level, and C1 inhibitor function are accurate, whereas earlier than that, there may not be as accurate. So we will often tell patients to wait till their child is 1 year old, and you want to get a C4 level, C1 inhibitor level, and a C1 inhibitor function. And why do we want those? So in type 1 hereditary angioedema, which is about 80 to 85% of patients, they are not producing the C1 inhibitor protein. And so the C1 inhibitor protein level and the C1 inhibitor protein function is going to be low. In type 2, they are producing the C1 inhibitor protein, but it doesn't work properly. And so in type 2, the C1 inhibitor level is actually going to be normal, but the function is low. And so you can ask, well, why don't we just check the function? And that's all we need. And I would say that's probably okay. You can check a C1 inhibitor function. You cannot just check a C1 inhibitor level, because then you will miss those 20% of patients that have hereditary angioedema type 2. And all in all, it really doesn't matter whether they have type 1 or type 2. Both of them present similarly. Treatment options are considered similarly. So truly then, getting a C1 inhibitor functional level is what you need. Having said that, you heard Tim say that sometimes the labs are a little bit confusing, where you have a parent, they have hereditary angioedema, 50% chance of passing it on to their child because it's an autosomal dominant genetic condition. And so if the lab values are a little quirky, they're kind of at borderline, you're not really sure, or they want to get them tested before they're 1 year of age, that is when you can look at genetic testing, but it's not required if you have a low C1 inhibitor function, you've already made the diagnosis.
So the genetic test is nice and easy too. It's a swab, so you don't have to do a blood draw in a child, and it's about $250, so it's relatively in line with what people can afford. And I do use it a lot, but I do the biochemical tests usually, unless they're very young. Even a 2-year-old, I might do the swab instead of sending them to the lab to get a blood draw, just so they have less stress associated with it. But
we have 3 more questions. I'm going to tell you your question, but don't answer it yet. I'm going to tell you your question, don't answer it yet, and I'm going to answer one of them, okay?
All right, sounds good.
Tim, your question is addressing heterogeneity of response to treatment. So soak on that. Your question is about repeated attacks in first trimester of pregnancy, what to do about that. My question is, what percentage of patients will only have abdominal pain as a sole symptom repeatedly, and what percentage develop respiratory symptoms as well in the panelist experience? So my experience in type 1 and 2 HAE, it is a disease of multiple areas. It is not just an abdominal situation. Respiratory wheezing is not a thing, and I would be considering alternative diagnoses. Laryngeal is a thing, so if that's the intention of the question about respiratory. So if a patient is only there are patients who tend to have more abdominal attacks. Maybe they underplay an attack subcutaneous somewhere else. All right, so Tim, your question is, can you address heterogeneity of response to treatment?
I don't know if I can, but I'll try.
It's from Canada.
What?
It's from Canada.
Is it?
HAEcanada.org. Yep.
Okay. So, yeah, if you look at phase 3 studies, though, the vast, vast majority of people respond very, very well to all these therapies. I should say, so berotrostat, is about 50%. The others fall into the 85 range, plus minus a few points. So in those that are in that 85 range, most people do very well. There's always 1 or 2 or 3 people that seem to be not responding. Now, some of those people, if you look at it carefully, though, are abdominal attacks, which often makes you think of their skin attacks go away, and they only have abdominal attacks. Is there something else causing that abdominal attack? And so that's concerning. Other people might have just hidden, they tend to have skin reactions a lot, and they go on therapy, and they go away, but they continue to have throat symptoms or abdominal symptoms, or a combination of both. And then you have to worry about, are these true attacks? So is this from stress and worrying about, having an airway attack, and could this be vocal cord dysfunction instead? So a lot of the heterogeneity in response to medications, I think, have a lot to do with maybe someone has abdominal problems, some other, milk intolerance or whatever, or some vocal cords. But there's no doubt some people respond better to one medication than others. The other problem is compliance. So some people think they're doing well, so I'm going to push this medication out to 5 weeks, and I'm still doing well, I'm going to push it out to 6. And then they start losing control. And actually, if you read the guidelines, I know we've had an argument about that before, the guidelines kind of suggest you should push out medication a little bit, and I don't believe it. We have all pharmacokinetic information showing these are the best doses. So I try to avoid to suggest to a patient that they should try to push their medication out, because then I'm worried about them losing control. I don't know if I answered the question.
Yeah,
but
I like it.
Okay.
Yeah, I thought Dr. Wedner's paper out of WashU, where he was doing like deep genotyping and comparing some responses, was kind of neat, but I think that's excellent. What about the pregnancy question, Alina? So it was in first trimester, multiple attacks.
Yeah, so it doesn't necessarily matter what trimester we're looking at. In pregnancy, what we know is about a third of patients stay the same, a third get better, and a third get worse, which just means we don't really know what's going on. But if I know that a patient is thinking about getting pregnant, right? So we're already going to make some decisions on what treatments they can use. And what we know is that the C1 inhibitor replacement product, so whether it's intravenous, subcutaneous, or recombinant, if we're talking about on-demand, we know that those are safe in pregnancy. And so we would already start thinking about those if somebody is doing family planning. If they are pregnant, then they should be on an on-demand medication that has data that is safe in pregnancy. And if their attack rate is high, then we do need to be thinking about prophylaxis in those individuals. And so to your question, if their attack rate is high in first trimester, then one, let's talk about long-term prophylaxis. And you want to make sure that you are adjusting the dose through pregnancy if it's a weight-based dose medication, because they are going to gain weight throughout pregnancy. And then ensuring that they have on-demand treatment and that they know how to use it and that they can administer it or have someone administer it as soon as the attack starts. So the same principles would apply. And so it's really thinking about the right treatments that are safe in pregnancy, making sure that we have long-term prophylaxis and on-demand available.
And that becomes very important, too, when we're looking at some of the medications that are going to have 6-month injection intervals, right? So you have to get this discussion early on so you know to stop and transition people off of the medications at an earlier time, so it's not running through the pregnancy. So it's going to be an issue on how you do that, and you have to start talking about family planning very, very early on.
Right.
I've got 1 minute. I'm going to finish with poetry.
Okay,
All
we
right.
knew you were going to do that.
We're going Emerson, okay? And it actually relates to what you said right as we were coming up the stairs. What an awesome run. 20 years, total renaissance in terms of what is available for these patients. To laugh often, to win the respect of intelligent people and the affection of children, to earn the appreciation of honest critics, to appreciate beauty, to find the best in others, to leave the world a bit better, whether by a healthy child, a garden patch, or a redeemed social condition. To know even one life has breathed easier because you have lived. This is to have succeeded.
Beautiful.
It is a joy working with you all. Thank you. And thank you, Medscape and Ionis for sponsoring this.